Hello everyone, welcome back to the second part of the liver class. In the last class, we came across normal features, general characteristics and special features of the liver, and we came across the surfaces, borders, relations of liver we have completed. So in this class, we are going to do the remaining part which we left in the previous class. So this class we are going to deal with lobes of the liver, fissures of the liver, ligaments of the liver, nutrition, otherwise we can call it as blood supply of the liver, lymphatic drainage and applied aspects of the liver. So coming to the first subheading, the lobes of the liver. The liver presents anatomically and physiologically right and left lobes, caudate, quadrate and sometimes the Riddle's lobe is also present. Anatomical right and left lobes are given here. You can see the image of the liver which is showing the anatomical anterior view of the liver, and here you can see a larger right lobe, a smaller left lobe will be seen. So these are demarcated in front and above by the attachment of the falciform ligament and below and behind by the fissure for the ligamentum teres and venosum. So you can see behind it is separated by the ligamentum venosum and as well as a teres, and anteriorly by the falciform ligament. The 5/6 of the liver is formed by the right lobe and 1/6 is by the left lobe. So the right lobe of the liver is larger when compared with the left lobe. And physiologically also we have the right and left lobes. We can say both are almost all equal in measurement. So this starts from anteriorly, a line starts from the just lateral to the right side to the falciform ligament, and behind if you observe the line passes from the groove for the inferior vena cava and the floor otherwise called as a fossa for the gallbladder and comes to the inferior border of the liver. So this line is called as a Cantley's line. So physiologically, which divides the liver into equal parts, almost all equal parts, right lobe and as well as the left lobe. So these lobes are called as a functional lobes of the liver. So this diagram shows once again the physiological right and left lobes of the liver. Within the physiological right lobe and as well as the left lobe, the hepatic duct and corresponding vessels divides each into anterior posterior branches. Similarly, within the lobe of the corresponding duct, the vessel divides medial and as well as the lateral branches. So these portion of the liver supplied by the each branches from a segment. Thus, the right lobe presents anterior, and this is the right lobe which is present the anterior segment and as well as the posterior segment. And the left lobe presents the medial segment and as well as the lateral segment. So there is no relation like the bronchopulmonary segments with these segments of the liver. The liver is having the greater capacity of the regeneration. So even 80% of the liver if you remove also, it has the capacity to regenerate very fastly. And we can see the 8 different segments seen on the both lobes of the liver. 1, 2, 3, 4, 5, 6, 7 as well as the 8 segments. So clinical anatomy concerned with these segments of the liver. The anatomy of the hepatic segments is still of uncontroversial. Usefulness is in partial resection of the liver. A large volume of the liver can be removed safely, healthily. Hepatocytes have the great capacity of the regeneration. So coming back to the other lobes, caudate lobe and as well as the quadrate lobe. So this caudate and quadrate lobes we have already dealt while we are reading about the posterior surface and as well as the inferior surface of the liver. So coming to the caudate lobe, it appears like comma shape. It is lies on the posterior surface of the liver. It is bounded on the right side by the inferior vena cava. We can call it as a groove for the inferior vena cava. On the left side by the fissure for the ligamentum venosum, and above by the posterior-superior border, and below by the porta hepatis. porta hepatis. So these are the boundaries of the caudate lobe. The lowest part of the caudate lobe presents two process, so caudate process and as well as a papillary process, so which extends into the inferior surface. The caudate lobe is the only part of the liver. The caudate lobe is only part of the liver which is covered with the peritoneum of the lesser sac. So this is important MCQ. The caudate lobe is only the part of the liver which is covered with the peritoneum of lesser sac. So remaining is in relation with greater sac. So coming to the quadrate lobe. The quadrate lobe is a quadrilateral in outline, bounded on right side by the fossa for the gallbladder and left side by the fissure for the teres, ligamentum teres, and above by the porta hepatis and caudate process, and below and in front is by the inferior border of the liver. Inferior border of the liver. So these are the boundaries of the quadrate lobe. So coming back to the relations, the quadrate lobe is crossed by the pyloric part of the stomach and first part of the duodenum. So this is crossed by the pyloric part of the stomach and as well as first part of the duodenum in the middle. And right free margin of the lesser omentum with its content in the upper part. So this is a place where the lesser omentum along with the contents will be seen. The transverse colon in the lower part and provided stomach is empty. So the transverse colon will be here. If the stomach is empty, the transverse colon will be coming in relation with this one. So this is a normal liver specimen which we will observe in the dissection hall. So here we will see the left lobe of the liver and this is a right lobe of the liver, and you can see the caudate lobe and this is a process, papillary process, and this is the quadrate lobe. And the Riddle's lobe. So sometimes a tongue-like projection arises from the lower border of the liver as a Riddle's lobe and extends below the right costal margin. So this is a place where if at all any tongue-like projection is seen, so that extension of liver we can call it as Riddle's lobe. Coming to the fissures of the liver. So fissures are nothing but these are the separate like line-like structures which divides the substance of the liver into the different lobes. So a non-peritoneal figure of H. A non-peritoneal figure of H will be seen. Fissures affect the inferior and posterior surface of the liver. So that cutting part will be seen on the inferior surface and posterior surface of the liver. The right limb of the fissure includes the groove for the vena cava. So this is the right limb which includes the groove for the inferior vena cava and fossa for the gallbladder. Whereas the left limb includes the fissure for the ligamentum venosum and as well as ligamentum teres. And the horizontal limb of the fissure forms the porta hepatis. So a non-peritoneal H-shaped fissure will be seen on the inner part of the, otherwise the inferior and posterior part of the liver is H-shaped fissures. So this is a right limb, left limb, a transverse connection. So right limb is by the inferior vena cava groove and fossa for the gallbladder. Left is by the ligamentum venosum, ligamentum teres, and the horizontal connection is the porta hepatis. And coming to the peritoneal relations, some parts of the liver, the peritoneum is not covered, it is only covered with the capsule of the liver. So they are nothing but bare areas of the liver. So there are 5 different bare areas: triangular diaphragmatic area, groove for the inferior vena cava, gallbladder fossa, porta hepatis, fissure for the ligamentum venosum. So coming to the peritoneal reflection, so here we can see how the bare areas are seen. So this is how we will see attachment of the lesser sac here, how the bare areas are forming. So this bare areas we can see, in the last class only we came across the boundaries, everything. Coming to the peritoneal reflections. The peritoneal reflections are nothing but the peritoneum how it covers the organ, and how it extends as a ligaments. So we can call it as peritoneal reflections, like lines of peritoneal reflections. So the right and left layer of the falciform ligament here are attached vertically on the anterior surface of the liver in between the anatomical right lobe and left lobe and diverges above. So we'll start from here. So this is a free edge containing of the patent paraumbilical veins and ligamentum teres hepaticus, a round ligament of the liver, obliterated umbilical vein. So this is extend upwards and in between the right and left lobes and diverges into the two. So after this, next thing we should see on the posterior aspect, how this ligament forms. So this is a right lobe and this is a left lobe. So after that, it forms the superior layer of the coronary ligament. After that, it continues down as a right triangular ligament and forms inferior layer of the coronary ligament. Then it crosses the inferior part of the groove for the vena cava and it forms the boundary for the caudate lobe of the liver, and then it forms the right margin for the ligamentum hepaticus and it extends into up to the porta hepatis. So after that it goes upwards as a greater sac part, then it forms as the left triangular ligament and comes downwards another layer of the falciform ligament. So this is how the line of extension will be seen on the anterior and as well as the posterior aspects of the liver. So coming to the peritoneal recess, the peritoneal recess, there are two recesses lies above the liver and two recesses below the liver. So that we can call it as right and left suprahepatic recess and right and left subhepatic recess. So in the right and left subhepatic recess, the hepatorenal pouch of Morrison is the most dependent part of the peritoneal cavity. So I think you are aware of this. Normally you will observe this one during the lying posture. I think you have covered in the peritoneum also. So that is very important 2-mark question which you are supposed to learn about that. So normally this hepatorenal pouch is mainly responsible for the accumulation of the fluid. So draining of the fluid, that is our empty space, most dependent place in the lying posture. So clinically also this place is very important, just like how the pouch of Douglas in the case of the pelvis. Coming to the ligaments of liver. So the liver is consisting of two types of the ligaments, peritoneal folds and true ligaments. The peritoneal folds are nothing but the folding layers of the peritoneum, connective tissue layer which is lined with the epithelium. So we can name accordingly falciform ligament, coronary ligament, right triangular, left triangular ligament, lesser omentum. So all these layers are nothing but folds of the peritoneum. So the grip given for this and support given for the liver is also a little bit less when compared with the true ligament. The true ligaments are nothing but ligamentum teres hepaticus and ligamentum venosum. So coming to the peritoneal relation, so here you can see the falciform ligament and right triangular ligament. You can see the coronary ligament, left triangular ligament. So in this picture, we can see the ligamentum venosum, ligamentum teres. So in this one, in addition to that, we should know the contents of the each and every ligament. So coming to the falciform ligament is consisting of ligamentum teres, paraumbilical veins, numerous small veins known as the accessory portal system of Sappe. So these are the contents seen in the falciform ligament. So coming to the coronary ligament, it is consisting of connective tissue so these are the coronary ligament. It is consisting of branches of the right inferior phrenic artery, communication between the systemic and portal veins, upper part of the right suprarenal gland and sometimes upper end of the right kidney contents. And coming to the lesser omentum, the lesser omentum it is very close with the lesser curvature and anastomosis of the right and left epigastric vessels, branches of the gastric nerves. Within the right free margin, you can see the portal vein, bile duct, hepatic artery, hepatic plexus and nerves will be seen. So this is just like a revision to you, which you have already completed the lesser omentum while you are reading about the peritoneum. So coming to the ligamentum teres hepaticus, It is a remnant of the obliterated left umbilical vein. It extends from the umbilicus to the left branch of the portal vein at the porta hepatis and passes along the free border of the falciform ligament and floor of the fissure for the ligamentum teres. So, this is the extension from anteriorly to the posteriorly, it will be extending like this. In the fetal life, the left umbilical vein conveys the oxygenated blood from the placenta to the fetus. And ligamentum venosum, it is a remnant of the obliterated ductus venosus, which in fetal life connect the left branch of the portal vein with the left hepatic vein and directly with the inferior vena cava. In fetal life, the most of the blood of the left umbilical vein shuts into the inferior vena cava via the ductus venosus after bypassing the hepatic circulation. So, here the image shows the lesser omentum and attachment to the caudate lobe porta hepatis. You can see here how it is communicated, the lesser curvature of the stomach. And this is a neck of the gallbladder, body of the gallbladder. Coming back to the blood supply of the liver. So, in very brief manner, the liver gets nutrition from the two different sources. Around 65 to 75% are derived from the portal vein. It is coming from the portal vein, which in spite is having the less oxygen content. It is charged with the absorption as a digested food. The portal blood reaches the hepatic sinusoids after passing successfully through the conducting vessels in the portal canal. Distributing vessels along with the sides of the two adjacent liver lobules impel venules through the holes in the outer limiting plates of the liver cells. And around 25 to 30% of the nutrition is derived from the hepatic artery, which is circulated at the pressure of 100 mm of Hg and conveys about 300 ml of the blood per minute. So, these hepatic arteries, again these are the branches coming from the celiac trunk. So, communication between the portal vein and hepatic artery takes place mainly in the sinusoids. So, arteriovenous anastomosis may be exist at the portal canals. So, it is supplied by the both, the blood is coming from the portal vein and as well as along with the hepatic arteries also the blood will be coming. One is oxygen rich, other one is a nutrition rich. So, exchange will be taken, the venous blood will be drained into the inferior vena cava through the hepatic veins. Coming back to the lymphatic drainage, the lymphatic drainage is relatively rich in protein. Lymphatics of the liver being blindly around the portal canals of the space of Mall. So, this part you will understand very beautifully once if you come across the histology of this. So, now you just remember that which part of the liver goes to the which substance. So, coming to the anterior and intermediate group of the supradiaphragmatic nodes, they drains the posterior surface and superior surface, right lateral surface. So, the lymphatics from these three areas, they drains into the anterior and intermediate group of supradiaphragmatic nodes. And next one is hepatic nodes. The inferior surface and adjoining part of the anterior surface together along with the porta hepatis, they drains in the hepatic nodes. And coming back to the paratracheal nodes, from the posterior surface of the left lobe, some vessels drains into the paratracheal nodes. Whereas the deep lymph nodes accompanies partly along the hepatic nodes, veins and partly from the portal veins and terminate respectively into the supradiaphragmatic and as well as hepato lymph nodes. So, directly drains into the hepato lymph nodes. So, this is a diagram, this will help you to understand. So, here with the different labelings they have given this one, many lymphatics they have mentioned, and here you can see some of the hepatic veins entering into the inferior vena cava, and with the labeling they have given the hepatic nodes, celiac nodes and phrenic nodes, lumbar nodes, everything they have given. So, this will help you to understand the arrangement of the lymph nodes along the two great vessels in the posterior abdominal wall, how the drainage will be goes. So, coming to the clinical aspects, so this is a we can observe this is a cirrhosis of the liver and this is a normal healthy liver. So, the hepatocytes sometimes may undergo the necrosis following their injury and death caused by the infections, some toxic over alcoholism and poisonous cases. The hepatocytes sometimes it will go for the necrosis. The dead hepatocytes are replaced by the fibrous tissue by the proliferation of the perilobular connective tissue. So this results in the hepatic fibrosis is clinically termed as cirrhosis of the liver. The patient develops jaundice due to the obstruction of the bile flow. Resistance to the blood flow through the cirrhosis liver is increased, which leads to the increased pressure in the radicals of the portal vein. So this will causes the portal hypertension. So these are the symptoms normally we will observe in the cirrhosis of the liver. And another important thing we come across is in relation with the bare area of the liver. The bare area of the liver is in direct contact with the diaphragm, so which separate it from the right pleural cavity. So surgically it is important because the enclosures the right extraperitoneal subphrenic space. So the amoebic hepatitis is pus may be collected in the space and forms the subphrenic abscess, so which may be burst into the right pleural cavity through the diaphragm. So a potential anastomosis of the venous capillaries exists in the region of the bare area between the liver and diaphragm. So it becomes the functional under certain pathological conditions, just like portal hypertension, to minimize the pressure over this one. So the normal structure, it will try to maintain the normal structure. Thank you so much.